हाँ।
हम लोग लिए थे ना।
नहीं नहीं नहीं, हम लोग तो 8 करोड़ का, बॉस 8 करोड़ का बोल रहे थे ना।
Hello.
Good afternoon, sir. You can start the class, sir.
Okay, okay. Just a minute. So I think I have to share the screen now.
Okay, sir.
I can. Shall I share the screen? Just a minute. I have to share the screen now.
Yes, sir.
Sharing option. There is a green color icon, na share.
Yeah, yes, sir. Green color icons.
Okay. This is the desktop. I have to click the share. Yeah. Okay. Is it visible?
ज्वाइन कर
Hello.
लिए एक बार आप. हाँ जी जी जी, एक बार आप ज्वाइन कर लीजिए सर. ठीक.
Yeah. Now I have played it.
सर, वेरी गुड.
Is visible now?
विजुअल.
Hello.
यस सर.
Can I start now?
यस सर. नो सर, ये पुनीत सर इज जस्ट ज्वाइनिंग.
Okay. Let Puneet join. Okay.
Yeah, good afternoon.
Good afternoon, Puneet.
Afternoon, Puneet.
How are you?
How are you? Just fine.
Okay. Can I start
Can I
now?
start now? Yeah, please.
Yeah. So,
So,
thank you very much for the opportunity to talk about insulin therapy. And I think, I'm a molecular biologist, and my primary area of research is looking into pathophysiology. But insulin, of course, my bread and butter. I'm practicing for the last 30 years. So I would like to share some of my experiences here. So insulin in type 1 and type 2 diabetes mellitus, the basic issue is, insulin molecule extraction from animal pancreas was a Nobel Prize winning discovery. Look at the molecule which is the most physiological. Whatever is the molecule that acts in your body, same molecule is there in the insulin that has been extracted, that was extracted. So from pharmacodynamic point of view, insulin is the square fit molecule. But medical science, industry, biotechnologists, and even the governments, everywhere effort was made to make right dose of insulin molecule at right place in the right person. And the century medical science failed to develop the technology to provide insulin in appropriate concentration to every cell whenever it was needed. And this failure led to the story of issues and controversies and tricks and tactics, as well as matters of clinical judgment, matter of art of practice, everything come in between to make the insulin available at right place, right time, in right dose, and the right cell. So with this background, there are several barriers to insulin therapy. Some are patient related. Cost of insulin, cost of glucose strip, very important consideration. By given government, it is free. Concern about weight gain and hypoglycemia. It's a very great concern whenever we start insulin. But you see, if we ask our patient that if you are doing good exercise, physically fit, you may not gain weight. So patient will say, oh, I will do lot of exercise and enjoy my eating by eating less. They will not gain weight, or weight gain will be minimal. Fear of injection, pain and needles. So my practice always say, oh, insulin is given through a pen or a syringe which doesn't cause pain. They say, oh, how it is possible that we are taking insulin by syringe? Then you tell, it is just कि चीटी काटते जितना सब फील होता है उसको एंजॉय करो. Second है lack of caregivers. That is very important concern because patient fear hypoglycemia. So sometimes we ask them to wear even CGMS because CGMS have alarm. The sense of personal failure. Many patients say, if I take insulin, that means I failed to control my diabetes many years, did not manage properly. I said, no, 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 no. It is good for you because insulin is the most potent ताकत का हार्मोन है. मैं हमेशा कहता हूँ कि अगर आपने ताकत की दवाएं सुनी हैं तो सबसे बड़ी जो सबसे पावरफुल ताकत की दवा जिस दुनिया में बनी है वो इंसुलिन, और वो सुनते ही मरीज बड़ा खुश हो जाता है. And believe that insulin therapy means that the diabetes has become worse. Again, they tell your patient, इंसुलिन हम तुम्हारे भले के लिए दे रहे हैं क्योंकि तुम्हारे बॉडी का मेटाबॉलिज्म अच्छा होगा और वापस रीजनरेट हो जाएगा. इस तरह के वर्ड को सुनते ही मरीज बड़ा खुश होता है. इसी तरह फिजिशियंस के बड़े बैरियर हैं कि फिजिशियन इसलिए नहीं देना चाहते कि उनके पास इंफ्रास्ट्रक्चर नहीं है डायबिटीज एजुकेशन का. ये बहुत बड़ा एक कंसर्न है, इसीलिए फिजिशियन अवॉइड करते हैं. मेरा ऐसा मानना है कि अगर आप डायबिटीज प्रैक्टिस करते हो और आपको इंसुलिन देना पड़ रहा है तो आप खुद ही इस चीज़ को सीखिएगा. इंसुलिन का इंजेक्शन मैंने तो अपनी प्रैक्टिस में पहली बार जब इंसुलिन किसी को प्रेस्क्राइब की थी खुद ही ने लगाई थी, और एक लगाने की टेक्निक ऐसी यूज करी थी उसको पेन नहीं हुआ. तो उस समय तो 31 गेज नीडल भी नहीं होती थी. तो एक तो अगर आप सोलो प्रैक्टिस करते हैं आपको डायबिटीज एजुकेटर का काम खुद करना पड़ेगा. आपको ही इवन मेरी प्रैक्टिस में एजुकेटर में कम रखता हूँ, खुद ही उसको सिखाता हूँ कि भैया कैसे मॉनिटर करना है, कैसे डोज एडजस्ट करना है. तो फिजिशियन को एटलीस्ट मिनिमम आना चाहिए डायबिटीज मैनेजमेंट में, कि उसके एजुकेशन पार्ट को. Now, insulin physiology overview. Insulin secretion tightly regulated to maintain normal glycemia, and it is not only regulates plasma glucose level, but also play an important role in lipid and protein metabolism. You see physiological insulin secretion shown on the left side in this. It is not very smooth. Even so-called basal, it fluctuates. It is high in the 5 o'clock to 8 o'clock. We call it down phenomena. It is related low between 3 to 4 p.m. And the peaks with come with the meal actually depends on the meal, its timing, patient stress level, patient gastric emptying, other drugs taken, the glycemic index of the food taken, the carbohydrate content of the food taken, and even diurnal variations are there. Physical exercise makes some difference. Some of the interfering drugs may also interfere the absorption. So it is a actually multi-dimensional phenomena, and a physician as a clinician, you should be aware of all those factors and then tailor-made your insulin regime. It is very important. You don't take into account your carbohydrate count of the meal. You don't take into account the pace of eating. You don't take into account your diabetic gastroparesis. You don't take into account your autonomic dysfunction. All these factors makes difference in absorption, and you have to tailor your treatment accordingly. Similarly, another important part of insulin therapy is that insulin not only control glucose. Actually, blunder mistake which everybody do, in my opinion, while managing diabetes, their focus is on glycemic control. I think one Minkowski has, Gary has once written long back, a Minkowski has been accusing because glucose theory is not a square fit theory of your all diabetes phenomena. And diabetes mellitus reflects not only your glucose metabolic dysfunction, but lipid metabolic dysfunction, which dominates in the pathophysiology, and protein metabolism. Apart from this, there is a lot of inflammation, oxidative stress, and so many things in the body in a diabetic patient. So insulin is the only drug which take care of most of these detrimental pathophysiologic processes. So insulin is said to be a wonderful medicine for diabetes, provide and it take care of whole pathophysiology of type 1 because there is a deficiency, and half of the pathophysiology of type 2 diabetes, that is your beta cell failure. Of course, half of the is insulin resistance. That should also be taken care in the management of type 2 diabetes. The types of insulin. We get confused. Bovine insulin, porcine insulin, insulin analog. So many drugs are coming in marketing. And unfortunately, most of us attend meetings which are actually supported and academically interfered by the industry who manufacture the insulin. And we get confused of the type of insulin. So what you're supposed to remember about the types of insulin is that its pharmacokinetics. Its onset of action, how many minutes or portion of an hour after taking your prick, taking the shot, when its peak come, and what is the duration of action. So don't worry about, we all have human insulin and we have human analogs. Bovine, porcine insulin we use when we were students or we were in early in practice. They are no more with us. So type of insulin means bother about is pharmacokinetics and profile of glycemic response. And types of insulin, try to understand. It is very important picture. I think it is, I've taken from Nature reviews, because I think there's some interference in my screen with the, just a minute. I'm not able to locate the cursor. Yeah, I can't, it is actually hidden on my screen with this picture. Insulin in nature, insulin in your subcutaneous tissue, insulin in your circulation, and insulin in the wire. There are three aspects. Try to understand. When you inject insulin, you think that everything is going into circulation. No. Insulin is a different molecular organization when it is in the vial. It has different, I mean to say, physiochemical orientation when it is in subcutaneous tissue. And it's, of course, circulation, but I think physical and chemical properties are different. You see, natural insulin exists in the form of hexamers. And the hexamers is around a zinc molecule. Even in pancreatic beta cell, insulin in the hexamers. These hexamers can be compounded with another compound. And for example, NPH insulin, protamine. Similarly, in your analogs, there are alteration in the hexamer structure and organization. There may be dihexamer in insulin retimer. Glargine has actually again hexamers, but they are in high concentration in subcutaneous tissue because change in pH. And glargine U300 has large aggregate of hexamers in subcutaneous tissue. Though it is hexamer in your vial, but it is a large concentrated hexamer. And your degludec has multi-hexamers. So these hexamers, when they are dissolved, they are in circulation. Some of them are detimir as well as your degludec, they bound to albumin. And they're bounding with the albumin slow, they are actually they so, so these properties of short insulin, regular or short acting insulin, intermediate acting insulin, long acting insulins. So you all know your insulin analogs like your this Lispro, Aspart, and glulicin. They are very rapid acting insulin. But in practice now it has been realized from the point of view of postprandial hypoglycemia and time to take insulin before your meal, it makes sense if you take a rapid acting insulin as compared to your short acting insulin. Your regular insulin, so-called crystalline insulin, is the regular insulin, because regular insulin onset of action after 30 to 60 minutes, peak at 2 hour, total duration is, I will come to that point in the next slide. Similarly, you have an intermediate acting insulin like NPH insulin, and you have long acting insulin like your degludec, as well as your datimir, as well as your glargine. But nowadays, some, once a week insulins are in development. And these two, Afsitota and Icodec, these are two insulins which are going to be once a week. So there's a lot of hype about the once a week insulin. People say, oh, week में एक ले लेंगे अच्छे रहेंगे. But as a clinician, I know once you have taken a dose, it will remain in your circulation for very, very long duration. And there are changes in your life. Suppose some intercurrent illness comes, or somehow you are able to miss your diet. There are several reasons, stress level, everything come. You have lost the opportunity to adjust your basal insulin. So personally, I am not in very favor of this once a week insulin, because once you've injected, if you want to make some change in the glycemic level, basal insulin level, you have to wait for 1 week for action to come. And after 1 week, some reason your diet is not perfect, your stress factor is gone, then you will every day have hypoglycemia. So I think if you have a good basal insulin once in a day, that is the best. Or even for 12 hours, you have basal insulin. In my personal practice, for example, GDM, I am using insulin datimir twice a day, because that gives a very smooth peakless profile. Patient doesn't bother actually more pricks. It is only psychological barrier. So best basal insulin in my practice is twice a day datimir for particularly pregnant women, because there this matters a lot. Now coming to actually one more concept, that is PT ratio, peak to trough ratio for basal insulin. For the basal insulin, if you give a insulin, you believe it's a basal. You see, I told in the first slide, your natural physiological insulin levels are not fixed throughout the day before meal. I'm talking basal condition or before meal condition. Down phenomena, sugar, glucose level goes high. Sometime before lunch, some people before dinner at 4 or 5 o'clock in the evening, there is a dip in the sugar levels. In pregnancy, because of the fetus, there is a very severe dip in the glucose levels. Regarding insulin, when we see their pharmacokinetics, its persistence in circulation, then its peak and its glycemic action. They are two different concepts. For example, your glargine has a little peak. Your datimir has very little peak. Degludec has negligible peak. Your NP has significant peak. So trough and peak level ratio, that is very important determinant of quality of your NPH, your basal insulin, and you have to adjust according to patient profile. This. Secondly, insulin glycemic action may persist for longer duration, for higher level when its levels are down. If you understand this concept, you will be able to solve many issues in your diabetes management. So this left side slide, photo is very important. For basal insulin, peak to trough ratio is fluctuation and glucose response and persistence in the blood of the glucose molecule. When you talk about the vial, which is given by a pharma company, they write the whole story. They write how is the duration, how long does it persist in the blood. But how much glycemic response, how long it goes, what is the degree is little different, and you must have an understanding of this. Because when I was a DM student, we are supposed to treat like physician your diabetes with short acting and NPH insulin. I remember many patients we were not able to control sugar, because after 5 to 6 hours of expected 4 to 5 hours of your regular insulin action, that is pharmacokinetic action of the vial or the glucose persistent in the blood, there used to be glycemic response to the same insulin, and patient used to go into hypoglycemia, then Somagi phenomenon, hyperpeak, and patient sugar remains always high. So with this understanding, you can solve the issue of that patient's sugar is not coming under control, rather increasing doses of insulin. Very common phenomenon in type 1 or type 2 diabetes management with insulin. You go on increasing insulin dosage, sugar remain 250, 300 range always. It is because glycemic response has different profile than your persistence of your insulin molecule in the circulation. And your insulin levels on the left side photo, you can see The dot 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 is your circulatory levels of insulin, and here is your basal requirement. They are never square fit. So art of managing diabetes with insulin, you try to match patient's insulin profile is glycemic response profiles. Again, I'm emphasizing, at the fourth time I'm emphasizing this word, glycemic response profile with patient's physiology. Physiology is conspired by his diet, mental stress, physical activity, gastric emptying, glycemic index of the food, carb content of the food, total quantity of food, content of fiber. So if you have all those factors in mind with your insulin profile and insulin glycemic profile, you can try to match as much that possible. And that is the art of glycemic management. Now coming to the what are the insulin available, what is their profile? We have rapid acting insulin. They are to be given as bolus and bolus basal therapy. We have a FIASP, aspart. Onset of action is 16 to 20 minutes. Peak is 1 to 3 hours. Remember, peak to glycemic response to food varies from patient to patient. Many of my patients who are having, a rapid absorption of food and they have rapid response. On the contrary, there are patients who are, slow gastric emptying. And slow gastric emptying, this insulin will not be square fit because gastric emptying is slow, food absorption is slow, and your action, food absorption might persist even 3 to 4 hours. For that case, I always prefer a regular insulin instead of insulin like Fiasp. So you try a simple percussion of the abdomen, give you an information, a patient symptom of post-meal fullness. Then even otherwise considered to be best is an unfit insulin. So we have a Aspart, Fias, which is a very rapid onset of action. Then we have ordinary Aspart, other than Fiasp, traditional one, which onset action is 20 to 30 minutes. It is not immediate. Actually, many people believe analogs immediate action start. This is, you must have heard from pharma people, but this is not fact. It takes some time, but this is shorter. Lispro, 30 minutes. Regular insulin, 30 to 60 minutes. I don't know why people use Lispro because its duration of onset of action as comparable as your regular. It is 30 to 40. So have say he one is your patient. Patient is slow eater. He takes lot of fibers. He has a gastric emptying problem. Your regular insulin is better. And patient has no urgency of timing. Some people say and do in practice, they say FIASP and this rapid acting analog of this Lispro, that is Limuje, whatever it is. I don't use this fancy item in my practice. They have only one advantage, they can be injected immediately after meal because their onset of action is 16 minutes, and one can take them if they miss it. That is the only advantage this insulin have. Then we have intermediate acting insulin, NPH insulin. Onset of action is your around 2 to 4 hours. Peak is 4 to 10 hours. And duration is 16 to 22 hours. It varies from actually dose. So if you are taking NPH in very small dose, its onset of action will be slow. Peak will be at 4 hours. Duration will be only 16 hours. You take double or triple of the same NPH insulin, peak of onset 2 to 4 hours. Peak will be at 8 hours, duration will be 22 hours. So it is very important determinant of insulin doses and insulin selection, how much dose the patient is taking. Suppose somebody is taking 35 units of NPH. Its action will be as good, duration action will be as good as 20 hours, 16 to 20 hours. But he is taking 6 units onset with this duration action will be only 12 hours. So it depends on the dose. Similarly, long-acting basal insulin, you have Datimir. It is relatively shorter. It is the only insulin which is almost peakless. Glargine has some peak. Actually, literature-wise, they say no peak, but I have seen in my practice, it depends patient to patient. Some people have peak with Glargine, particularly early in the morning. Degludec I have seen patients having severe hypoglycemia. You do anything possible in this earth to control hypoglycemia day, but they develop it. So there are certain, drugs get accumulated in the body and it gets some severe peak also. So don't depend on what pharma people say, what pharma industry say, what is the literature say. These insulins are peakless, but they are not true peakless in when they are in circulation because they are not square fit to patient pathophysiology. Whatever data they see based on the animal experimentation, all those things. But patient might be having some tendency to hypoglycemia at a certain time. At that time, insulin is concentration remain the same in the circulation, but because of patient pathophysiology, there is a fall in sugar values. So never trust pharma people's word. Oh, it is peakless. It never cause peak. There may be variation in your patient itself. Even your so-called steady level of same insulin, this will be peak for glycemic response. That will be a trough for a glycemic response. So try to understand your patient first, and then plot on them your insulin profile. Then you have insulin combination, NPH regular 30/70, Lispro 50/50, Lispro 25/75, SPAR 30/17, all these are there. And these insulin mix, I rarely use them. Of course, in type 2, sometimes I use them. But I say these were actually developed for blind peoples. Two types of blinds. Patient who is blind and he has no support, he can't mix two insulin. Of course, in that case, they are very useful. And secondly is the doctor who himself is blind to his patient's pathophysiology and he doesn't want to indulge in all the pain of insulin dose adjustment, titration, all those things, then he can blindly write 30/70 with some glycemic content. And smart people, what they do, they ask patient to do self-monitoring at 4, 5 o'clock in the evening and 5 o'clock in the morning. Always their peak 30/70 come at these two times. Patient remains happy, oh, my sugar is under control. But whole day sugar is uncontrolled. So pre-mix insulins are basically meant for a very, very selected use. And the another advantage of pre-mix insulin, that some people who are already controlled on this much 30/70 50/50 combination and type 2 patient who require little amount of insulin, then you can give this type of medicine to match if it square fit their patient requirements. It is a rare happening. Now, insulin delivery in ambulatory. I will not talk about intensive care. Any question? I can hear some voice. In OPD practice, the most common route of insulin administration is subcutaneous. IV infusion is given in acute hyperglycemic condition and critical care surgical care. Inhaled insulin also now approved for clinical use in India. And you know all these things. You have pen, syringe, pumps, and inhalers. So I have made personal views on inhalers because still we are not, we don't have a 20, 30 years data to say that they are 100% safe. So, but it is your choice because they are approved in market. So pen have certain advantage, more convenient insulin delivery, more accurate dosing, less pain because small gauge needles, less intrusive, socially more acceptable, more flexibility because of disposable or reusable options. So pen have certain advantage, but they are expensive. But syringe are less expensive, allow use in split mix regimen. Patient can see the number of scales line together to have accurate dosing. Of course, dosing errors are more with syringe. Those who have visual problem, definitely is a problem. But if you want to mix two insulin, same syringe, this is only possible with your insulin syringe. So pen is either used for basal bolus regimen when the different insulins are given at different time, or some lucky patient control on 30/70 50/50 combination or regular as well as NPH, or your luckily control on ratio of degludec as well as this SPART, your so-called Rhizodex. Sometimes you can use pen for them, but we have to, if we want to mix two insulin, it is only possible with the syringe. Now, question is, if you have injected insulin, you believe that it will come into action and the action will be same? No, it is not true. If you take insulin in the lower limb and do some exercise, there will be rapid absorption. This will lead to hypoglycemia, then rebound hyperglycemia. Very common mistake. Local massage after giving insulin will lead to increased absorption. That should never be done. If there is a local heat for any region, that will lead to increased absorption. Insulin absorbed faster from the abdomen, less clinical relevant with long and intermediate insulin because their onset doesn't make difference, but it is slowly absorbed from faster from your abdomen. Lipohypertrophy will lead to erratic absorption. So one of the major reason for uncontrolled sugar I have seen in my practice in type 1 particularly is your lipohypertrophy, because patient love to inject a hypertrophy side because less painful, and that will lead to actually erratic insulin absorption, sometimes no absorption, sometimes uh, unpredictable absorption, and that will lead to fluctuation in sugar value. Larger the insulin dose, more prolong the duration. That you should always remember. I told previously, 6 units of NPH is a different profile. 60 units NPH, 60 we don't inject, but insulin tissue, it is large, it will disperse slowly. If it is small, physical and reduce variability. Very common mistake. Patient take the vial out without suspension, inject it, and that is the reason the insulin doesn't work. Then insulin storage guidelines. Very 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 complex subject. When we say patient insulin का क्या करना है, फ्रिज में रखना है, आधे मरीज तो उसका के फ्रीजर में रख देते हैं और इंसुलिन डी नेचर हो जाती है। आधे मरीज हमारे, हम कहते हैं भाई तुम्हारा फ्रिज नहीं है तो एक वो लीजिए अपना थर्मस और उसमें बर्फ के ऊपर रख दीजिए। अगर आपने बर्फ के ऊपर रख दिया तब भी वो खराब हो जाएगी। आइडियली इंसुलिन शुड बी, देयर आर टू थिंग्स। एक तो होता है इंसुलिन अनओपन, एक होता है ओपन वायल। ओपन वायल यूजुअली 4 to 6 वीक्स तक 25 डिग्री सेंटीग्रेड तक रख सकते हैं। ये कॉमन मेरी पेशेंट को एडवाइस है कि आपके घर में अगर एसी चल रहा है और आप रहते ही ठंड की जगह में हैं और आप सर्दी के मौसम में, हमारा टेम्परेचर कभी भी 25 से ऊपर नहीं जाता, तो हमें अननेसरी इंसुलिन को फ्रिज में रखने की जरूरत नहीं अगर हमने वायल खोल ली है। और अगर हमने वायल नहीं खोली है तो हमें उसको 2 to 8 डिग्री सेंटीग्रेड पे रखना। तो हम कहते हैं अगर फ्रिज में रखना है तो उसमें बटर वाली जगह रखना, पर बटर की जगह भी आजकल फिक्स नहीं है, बड़ा कंफ्यूजन है। आप बोलो नीचे रखना है, ठीक है ना, आपको फ्रीजर से थोड़ा दूर ही रखना है, क्योंकि हीटिंग इज आल्सो डेट्रीमेंटल एंड फ्रीजिंग इज आल्सो डेट्रीमेंटल। हम एक्चुअली हीटिंग को तो याद रखते हैं और उसका रिस्क तो याद रखते हैं, हम फ्रीजिंग का रिस्क याद नहीं रखते हैं। इसीलिए कभी भी इंसुलिन के वायर को आइस के ऊपर नहीं रखना है, और अगर आपके सर्दियों के दिन है तो अंदर रखना जरूरी नहीं है। और लास्टली मोर इम्पोर्टेंट, जो मैन्युफैक्चरर जो आपको एडवाइस देता है इंसुलिन वायर के साथ में, उसको फॉलो करना चाहिए। सिमिलरली हमारे चूंकि राजस्थान में टेम्परेचर 48 45 जाता है, उस समय डेफिनेटली इंसुलिन सेफ रखना। पर्टिकुलरली हमारे जो मैनुअल वर्कर होते हैं वो बड़े कंसर्न रहते हैं, साहब मैं अपने काम पे जाता हूँ वहाँ इंसुलिन कैसे रखूँ। उसका बड़ा सिंपल तरीका है, एक अपने मिट्टी का बर्तन लीजिए, इंसुलिन की जो आपकी वायल है उसको आप एक प्लास्टिक के उसमें डाल के और ठंडे पानी में डाल दीजिए। उसमें आपका 25 डिग्री सेंटीग्रेड से नीचे का टेम्परेचर होता है, इंसुलिन आपका सेफ प्रोटेक्टेड रहता है। इसी तरह कई लोग हैं जिनके वर्किंग ऑफिस वर्किंग है और एसी कार में जाते हैं और ऑफिस भी एसी है, तो उनको कोई दिक्कत नहीं, अपना पेन जेब में रख के ले जा सकते हैं। तो ये 2 to 8 डिग्री इज गुड फॉर लॉन्ग टर्म एक्चुअली वायल स्टोरेज, नॉट फॉर योर वायल इन यूज। तो इसलिए इस ठंड को लेके ज्यादा कंफ्यूज नहीं होना है, क्योंकि कई लोग कहते हैं इंसुलिन इंसुलिन लगाने तो मेरे पास फ्रिज नहीं है। हम कहते हैं भैया जरूरत क्या है उसकी। सिमिलरली इंसुलिन को लगाया कैसे जाता है, आई थिंक मेरे को जो पुनीत ने कहा था, ज़्यादातर जो क्लिनिशियंस हैं इसमें जो इंटरनल मेडिसिन प्रैक्टिस में हैं और सबके पास डायबिटीज एजुकेटर नहीं है, तो हम आपको कुछ इंपॉर्टेंट स्टेप बनाना चाहते हैं। देखिए इंसुलिन को कैसे लगाना होता है, सबसे पहले हाथ धोने होते हैं, फिर आपको इंसुलिन पेशेंट को बताना होता है, इंसुलिन की एक्सपायरी डेट चेक करें, टाइप ऑफ इंसुलिन चेक करें, फिर इंसुलिन को रूम टेम्परेचर पे लाना होता है। ये बहुत बड़ी मिस्टेक होती है। अगर क्लाउडी इंसुलिन है तो उसको बोतल को रोल करना होता है हाथों के बीच में, ताकि उसकी क्लाउडीनेस पर्टिकुलरली एनपीएच या 3070 इंसुलिन के लिए वो उसका होमोजेनाइज हो जाए। टॉप ऑफ द इंसुलिन बोतल को आपको अल्कोहल स्वाब से क्लीन करना चाहिए हर यूज से पहले। सबसे पहले आपको सिरिंज में एयर इक्वल टू द डोज लेनी चाहिए और उसको उसमें वायल में डालना चाहिए। रबर के बाद 90 डिग्री के ऊपर ही आपको सिरिंज रखनी चाहिए। उसके बाद एयर पुश करने के बाद आपको बोतल को उल्टा करना होता है, फिर आपको खींचना होता है। सबसे कॉमन जो इशू आता है वो एयर बबल का है, इसलिए धीरे 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 करना होता है। अगर एयर बबल आता है री इंसर्ट करिए, दोबारा खींचिए। एक जो हमारी इंडियन गाइडलाइन कहती हैं, हालांकि वेस्टर्न पीपल इसको नहीं करते हैं, कि इंजेक्शन साइट को अल्कोहल स्वाब से क्लीन करिए और उसको कंप्लीट ड्राई होने दीजिए। कई लोग हमें कंप्लेंट करते हैं सर इंसुलिन लेने के बाद उनके दर्द होता है। उसका रीजन ये है कि वो अपनी साइट को जो अल्कोहल से क्लीन करते हैं और अल्कोहल को ड्राई नहीं होने देते हैं, उसकी वजह से जो अल्कोहल सबक्यूटेनियस जाता है वो पेन करता है। ये बड़ी इंपॉर्टेंट प्रिकॉशन है कि सब इंसुलिन लगाया पेन हो गया, इसलिए कि आपने अल्कोहल लगाने के बाद उसको ड्राई नहीं होने दिया और अल्कोहल ने पेन कर दिया। सबसे इंपॉर्टेंट प्रिकॉशन है, इंसुलिन को इंजेक्ट करने के बाद आपको 10 सेकंड तक सिरिंज को बाहर नहीं निकालना है। क्योंकि मोस्ट कॉमन कंप्लेंट सर हमने लगाया और इंसुलिन तो बाहर आ गई, इसलिए 10 सेकंड आपको काउंट करने हैं इंजेक्शन करने के बाद। उसके बाद आपको नीडल को बाहर निकालना है। और अगर आपको उसको अगर आप वैसे तो सिंगल यूज की होती है, और हमें तो गवर्नमेंट सप्लाई आजकल सिंगल यूज के लिए हर एक को एक एक डोज के हिसाब से सिरिंज दे रहा है, पर रीयूज करना है तो उसकी उसको कैप लगा के रखना है। इसी तरह एक मिस्टेक होती है जब हम लॉन्ग एक्टिंग इंसुलिन, इंटरमीडिएट एक्टिंग इंसुलिन और शॉर्ट एक्टिंग इंसुलिन को मिक्स करते हैं। उस केस के अंदर हमेशा सबसे पहले जितना आपको इंसुलिन एनपीएच या इंटरमीडिएट एक्टिंग ड्रॉ करना है, वायल को सीधे रख के उतने यूनिट की हवा उस वायल में डालनी है और सिरिंज को बाहर निकालनी है। जब आप रेगुलर इंसुलिन ले रहे हैं या शॉर्ट एक्टिंग इंसुलिन ले रहे हैं तो भी आपको हवा डाल के पहले उस रेगुलर इंसुलिन को आपको निकालना है, फिर एनपीएच की वायल से एनपीएच को निकालना है। गलती क्या होती है, अगर आपका एक ड्रॉप भी एनपीएच इंसुलिन आपका रेगुलर इंसुलिन के वायल में चला गया तो पूरी की पूरी वायल आपके इंटरमीडिएट इंसुलिन में कन्वर्ट हो जाती है। ये ऐसे छोटे छोटे एरर्स हैं जिनकी वजह से बहुत लोगों के पेशेंट के शुगर कंट्रोल नहीं होती है। तो ये बड़ी इंपॉर्टेंट प्रिकॉशंस हैं। वायल को रोल करना, वायल को चेक करना, ये चेक करना वायल में कोई इम्प्योरिटी तो नहीं आ रही, कलर चेंज तो नहीं हो रहा है, ये हमें बार बार पेशेंट को बताना है। इसी तरह इंसुलिन इंजेक्शन साइट को डॉक्टर द्वारा चेक करना, अगर वहां लाइपो हाइपरट्रॉफी वहां इंजेक्ट नहीं करना है। इन्हीं गलतियों की वजह से ही, यानी कि इनको जनरल प्रिकॉशन नर्सिंग लेवल मिस्टेक की वजह से ज्यादातर हमारे पेशेंट का शुगर कंट्रोल नहीं होता है। नाउ इंजेक्शन टेक्निक के साथ एक इंपॉर्टेंट होता है कि हम कहते हैं ना सबक्यूटेनियस वी हैव टू मेक ए पिंच ऑफ द दिस, दैट इज वेरी इंपॉर्टेंट। अगर आपने ज़्यादा बड़ा पिंच ले लिया तो आप मसल में इंजेक्ट कर जाएंगे, आपने बहुत ही सुपरफिशियल लिया तो स्किन में एब्जॉर्ब कर जाएंगे। जो आपकी सिरिंज होती है उसकी लेंथ होती है 8 मिलीमीटर, 31 गेज हो भली, हालांकि कुछ सिरिंज में चेंज भी हुआ है। और आपकी जो पेन होता है उसमें 4 मिलीमीटर होता है। तो पेन में यूजुअली इंट्रामस्कुलर जाने के चांसेस बहुत कम होते हैं, क्योंकि हमारे यहाँ गवर्नमेंट में पेन मिलते हैं आजकल और उसकी नीडल भी हर एक को अच्छे नंबर में मिलती है, तो ये इश्यूज नहीं है, पर दे आर वेरी इंपॉर्टेंट इशू। जहाँ तक इंसुलिन साइट्स का है, ये लेफ्ट साइड के राइट साइड के फिगर हमने दिखा रखा है। अराउंड द अम्बलाइकस इन द एब्डोमेन, ओवर द बटक्स और ओवर द बैक, अपर आर्म्स एंड सम पीपल यूज इन अपर थाई। लेग में इंसुलिन अवॉइड करना चाहिए। सम पीपल इंजेक्ट इन द लेग आल्सो, दैट शुड नॉट बी डन। तीसरा है, जब इंसुलिन इंजेक्ट करते हैं नीडल को 90 डिग्री पे रखना होता है, नॉट 45। 45 से इंट्रामस्कुलर जाने के चांसेस होते हैं। और ये छोटे छोटे एरर्स हैं जिनकी वजह से ज्यादातर पेशेंट की शुगर कंट्रोल नहीं होती है। और इसका प्रॉपर डिस्पोजल ऑफ नीडल वेरी इंपॉर्टेंट। तो ये एक जो मैंने लेफ्ट में लोअर फिगर दिखाया है, ये क्लियर कट बताता है कि अगर आपने जब स्किन को फोल्ड करते हैं सबक्यूटेनियस टिश्यू को, एंश्योर इट शुड नॉट टेक द मसल और इट शुड नॉट बी एज पिंच कि आपका खाली स्किन ही आ जाए। दोनों को आपको अवॉइड करना है, ये बड़ा इंपॉर्टेंट पार्ट ऑफ मैनेजमेंट है। नाउ ग्लूकोज मॉनिटरिंग, सो वी ऑलवेज गिव पेशेंट ए डायरी वेयर दे मेंटेन द लॉग। उसको लॉग को देखते हैं, हमारे तो क्या होता है आंखें स्कैनर की तरह उसको लॉग को पढ़ती है, 1 मिनट समझ में आता है कहाँ गड़बड़ हो रही है। क्योंकि मान लो किसी के कहीं एकदम एब्रप्ट ऊपर नीचे चलेगी, या तो टेक्निक फॉल्टी है, या लाइपो हाइपरट्रॉफी है, या कुछ खाया है। सिमिलरली आपका ये कंटिन्यूस ग्लूकोज मॉनिटरिंग मोस्ट पेशेंट यूज करते हैं, तो इसके जो पैरामीटर्स होते हैं, टाइम इन रेंज 70% ज़्यादा ना होना चाहिए, बिलो रेंज लेस देन 5% होने चाहिए, और आपके वेरी लो तो दे शुड बी लेस देन 1%। और आपकी ये जो कर्व दिख रहे हैं, ये आर वेरी गुड गाइड टू रिमेंबर. विद दिस यू कैन प्रेडिक्ट वेयर इज वी आर रॉन्ग. एंड इफ यू आर एक्सपीरियंस विद दिस प्रोफाइल, यू कैन रियलाइज कि अरे ये तो सबक्यूटेनियस हाइपरट्रॉफी हो रही है, जिसकी वजह से इसके रेटिक एब्जॉर्प्शन हो रहा है, या इसने इंसुलिन ओमिट करी है, या जलेबी खाई है. आई कैन शो मेनी पेशेंट जलेबी खाते हैं, हम पकड़ लेते हैं इसके ऊपर. तो दिस CGMS का जो आपका ग्राफ होता है, और ये जो ऊपर उसका प्रोफाइल है, उससे आप प्रेडिक्ट कर सकते हो कहाँ गड़बड़ हो रही है. समटाइम्स सोमाइगेफिना डोमिनेट्स, समटाइम योर down phenol dominates the picture, and they all can be very easily picked up in the CGMS, and then you can take decision accordingly. Side effect of insulin: hypoglycemia. You see, this is the most scared. Hypoglycemia is the main concern about, because बहुत पेशेंट क्रिपल्ड हो जाते हैं, बेड रिडन हो जाते हैं, वेजिटेटिव हो जाते हैं. और हाइपोग्लाइसीमिया मैनेजमेंट हर डॉक्टर को, हर पेशेंट को बताना जरूरी है. एंड रिमेंबर, टेल द पेशेंट सिम्टम्स. If he has symptoms, he monitor, it's okay. If he doesn't monitor, don't worry. He has to take glucose, 15 gram glucose. Then check sugar again after 15 minutes. That is very important. But we say कि भैया 3 चम्मच चीनी खा लेना, हो गया काम खत्म. और खाना खा लेना. No, this is wrong. Check after take 15. Check for 50. Then it's systemic allergy twice in my life, edema, anaphylaxis. I've seen in one patient, two patient life, and desensitization is the only solution. Then we have a protocol, very, very low dose, bone increasing and desensitization. And that should always be done in ICU under supervision. And I prefer somebody from allergy department should be present along with you. Then insulin lipoatrophy, it is rare now with the human insulin and anal. But hypertrophy is quite common, and hypertrophy is only to be palpated on the part of abdomen, and then you identify. Insulin edema, very relatively rare, but it happens that patient we start insulin, patient developed edema, and that edema is because of insulin therapy, and rare, of course, weight gain is there with insulin. Now coming to insulin regimen. Okay, so now what are the insulin regimens available? I think insulin pump therapy is a good option. Previously, the data said insulin pump has no advantage of multiple subcutaneous insulin injections. But recently, a data has emerged. There may be some of the meta-analysis, there may be 0.23% improvement HbA1c. So it looks like there is a marginal benefit of pump therapy. Actually, pump therapy is something very specialized thing. I will not go in detail of pump therapy. And there are different types of pumps. Some are actually open loop, closed loop, all those things. Then there are some pumps with warning and all these things. But some patients prefer pumps, some do not. And I think most of the developed countries, at least where the third party payment is there, pump is restricted to type 1 patient, not to type 2 patient. So type 1, actually pump therapy requires a lot of commitment on the part of patient and commitment on the part of caregiver team. Because patient need to be educated. They need to wear the pump all the time. That is nothing, syringe lagai and you forget it. They have to either closed loop is very expensive, 7 lakhs rupees, and then monthly cost is around 20-25,000 rupees. If you use this traditional pump, which costs 2.5 lakhs, then you have to do CGMS or 6-7 time monitoring, and you have to adjust the doses accordingly. In my opinion, only situation where pump is really benefit is nocturnal hypoglycemia. And we are not able to match 3 a.m. fall and 5 a.m. rise in sugar. There is no insulin therapy available in this to take care of that fluctuation. And this is my personal view. I recommend pump for the patient who has nocturnal recurrent hypoglycemia and hyperglycemia in early morning. And we are not able to control their fasting sugar, though there are so many tricks and tactics to take care of that part. But that is a situation where really pump is useful in my opinion. Otherwise, It's, in my opinion, it is my personal opinion, it's more of a fancy item. Similarly, multiple dose insulin, long acting and flexible dose of ultra rapid acting or rapid acting insulin. Now try to understand what I am saying you. In this regimen, starting dose of induction is approximately 0.5 unit per kilogram body weight. I am talking type 1 patient because patient usually come in ketosis control. They are little insulin resistant. We switch over to subcutaneous insulin after recovery of DK, or patient has come without DK but very high sugar. So usually induction of treatment starting dose in our practice is 0.5 unit per kilogram body weight. I have 10 minutes. Okay. Then this to be given long acting insulin in the form of actually if we are using glargine U300, it definitely better than glargine. If patient is ready to take twice a day basal insulin, then of course datimir or glargine twice a day are very good option. Or patient is not willing to take two injection, then one injection of basal, that is your glargine U300 or degludec. These are the options. Degludec onset of action and duration is prolonged and it is over 42 hours. Then monitoring to be done for basal insulin every morning or before dinner if it is done twice a day. So doses are to be changed at least only twice a week. Every third day you have to make the change. What happens? We start insulin, we start with dose, next day sugar high, the same day we increase the dose. That is the blunder mistake. Once you started a dose, don't worry about stabilization, take even up to 5 to 7 days for even every insulin. But at least with glargine twice a week, glargine 300 twice a week, datimate twice a week, degludec every 5th or 6th day. If you started a dose, plateau level we achieve on the 5th day. Some people say degludec dose adjustment on the weekly basis. And secondly, you check pre-meal sugar and decide your dose according to carbohydrate content of the diet, carb count patients should understand, insulin sensitivity factor, and correction factor. On the basis of these three factors, it comes by practice. You decide the dose every time before the meal. So if patient take 4 times, then he has to take 4 times rapid acting insulin, like your Fiasp, your glulicin, or even Aspart or Lispro. So these insulin to be taken before meal. Every time you eat, you take regular insulin, and dose to be determined by your three factors. One is your carb count of the diet, your insulin sensitivity factor, as well as your existing sugar value. We have to give a correction dose. And this is the regimen which is little expensive. If it is combined with CGMS, it is very fine because there are certain CGMS protocol where the decline in sugar level also identified, and that is one of the reasons for changing the sugar. Or rising trend is also a factor. So it is a cumbersome, expensive, but gives the best result because you're not having a fixed dose. Rather, you decide the dose every time you will treat. So what my clinical practice is, what I do, first, I start with the glargine U300 because it is available free of cost in our institution, or degludec. Then started dose, monitoring, fasting, and dose is divided into 40% of the basal and 20-23 major meals, depending on the size of meal, 15%, 20%, 10%. Divide 3 in that. And I first try to adjust the base of fasting sugar dose of your long-acting insulin. Once your fasting sugar in the range of 90 to 130, my own personal value 90 to 130, because that's a better flexibility to start with. Then I check for post meals, or if I give regular insulin pre-meals before the next meal. So on the basis that I have induction, then I come to this maintenance phase. I do this type of adjustment based on insulin sensitivity index that is calculated by total daily 1500 divided daily dose. That is a correction factor. And your carb count. That comes later stage. So this is a very successful and energy regular insulin. So you if 50% of the daily dose calculated 0.5 units to Western people. Our people eat more in dinner or something, depending on that, you have to adjust it. And dose is adjusted according to your fasting sugar or 3M sugar, your NPS dose, and post meal or before next meal, basically you decide the dose of short acting, rapid acting analog. So this is how you adjust dose. So you start with a fixed dose and then make an adjustment. So dose is given before and you make the adjustment on the next day. Third regime is when you give a fixed dose of regular instead of short acting analog, otherwise strategy is same. Then 3 injection daily N plus R plus N plus rapid acting insulin. So in this regimen, pre-breakfast, 2/3 of the total dose is given before breakfast, 1/3 is given before dinner, and after that about 1/3 is regular and 2/3 is NPH. So this is one regimen with fewer daily injection you can do, but this is the best insulin regimen for those people taking 2 major meals. Because many of patient takes 11 o'clock lunch or 10 o'clock lunch and 5 or 6 o'clock dinner, 7 o'clock dinner. And they take a small meal in between. So these type of people we can use and they can't afford. This is a good option, this regimen. And lastly is twice daily split mix. This is an option for the patient who can't afford anything. They are old age, they don't want to, they are not at very high risk of hyperglycemia related risk, or they have long duration diabetes, they never develop complications, they're unlikely to develop 40 years of diabetes, no microvascular complications, they're unlikely to develop those complications. Age is 80 years. So the unnecessary poke them so much of insulin is unwanted. So for those patients, you have they have visual problems. So you have split mix, either 30/70, or you take R and N in the same syringe, give twice a day. Then what we adjust the diet according to insulin. Many patients like it. They take twice insulin. They take one heavy meal after morning injection, another heavy meal after evening injection. Then they take a small meal after 4 hours, and again a very small meal after 8 hours of insulin. So in the morning, they take lunch, they take insulin, then they take a small meal at lunchtime, otherwise lunchtime in afternoon. And late evening, they take a very small snacks, then they take evening dose, take dinner, and after dinner, they take some milk sort of thing to take care of peak of NPH insulin. These are the regimen. So you have to adjust it according to your patient lifestyle. So these are the merit demerits the regimen. Now coming which regime to be used in whom? Very simple. Basal bolus is the only therapy for type 1. Never use mixed insulin in type 1. But in type 2, you can start with basal. Sometimes basal does wonderful job with your oral hypoglycemic drug, particularly your GLP-1 analogs. Sometimes some patient I do in my practice start with basal unit because basal unit more than 0.5 unit per kilogram body weight, it doesn't work. So I give 130/70 insulin before breakfast. Sometimes it does good job. If all fail, then of course we have to start with premix insulin. Now coming to type 1 management specific aspect, type 1 patient, there are 3 factors. One is age of the patient. Because what are the indications for insulin? Patient has no clinical features of your insulin resistance like acanthosis nigricans, acrocardia, hypertension, all those things. Patient has no family history and antibodies are positive. So these are algorithms to say these are basically type 1 patient. They are the candidate for insulin therapy. There are people who have MODY diabetes, you have to go for genetic testing. There are people who are antibody negative. I will finish in next 3, 4, 5 minutes. In that case, you can, if patient is age more than 35 years, you can start insulin. You can start with oral. And after 3 years oral, if this is a C-peptide, if C-peptide is 0.6 nanogram per ml, I think 200 picogram per liter is another in the other unit, then there is a possibility of type 1. If it is more than 600, your type 1 is ruled out. So these 4 determinants, age, family history, other features of type 2 diabetes, C-peptide level, and antibodies. They decide on the basis you can say who are the right candidate for insulin. Regarding glycemic target, pre-meal 90 to 130, post-meal best you can have 140, but the way up to 180, HbA1c 7, time in range on CGMS less than 70%, below hypoglycemia less than 1%. Then of course, type 1 management insulin, one of the therapies, lifestyle control, and these are all important components of treatment. You should match your insulin therapy with them. Then even when with insulin and on all your best efforts, sugar not control, look for patient psychology, look for barriers to use insulin, look for intercurrent illnesses. And there are so many factors this and the control. So you look for all those factors to make your glycemic targets. Take type 2 diabetes management. It is very simple. If your all oral drugs fail, try GLP-1 analogs. If it doesn't work, eat basal insulin. Sometimes we give actually insulin before this situation in type 2 when immediately after diagnosis 1 month of insulin therapy sometimes preserve beta cell and patient might not require any insulin throughout their life. That is indication. Any intercurrent illness you have to give illness. Any severe hyperglycemic episode you have to give insulin. And of course first therapy is with the oral drugs. Add your basal therapy. Basal therapy, if dose exceeds 0.5 units per kilogram body weight, that is unlikely to work. You are not able to achieve target. Then one insulin regular before major meal. Or if the two meals post meal are high, then you can add one 30-70 sort of insulin. Or if all this fail, then you have to give basal bolus therapy like your type 1 diabetes mellitus. So thank you very much for your patience hearing. Yeah. Any question?
Sir, some question chat box, sir.
Okay, can anybody read it or I have to open the chat box? Just I'm trying to open it. Yes. Patient type 2 DM who cannot afford GLP analogs, can we give insulin with other, which is, yes, it is a very pertinent question. Actually, personally speaking, because my original research is in the field of sick fat and Indian phenotype, you see for Western countries, type 2 diabetes is a manifestation of obesity, overweight, or high BMI. Indian type 2 problem is because of severe insulin resistance, because of sick fat or adiposopathy or sick fat disease. And in this scenario, GLP-1 analogs are not good option. So your non-obese patient, when they are not responding to oral drugs, first we should try all insulin resistance reducing drug, particularly use of glucagon. Even I know my relative who was treated with all the fancy items for I think 15 years, and now he's a very CEO of a very big company, and now he has been put on pioglitazone 15 despite his BMI is 35. So for Indians, oral drugs, particularly insulin resistance reducing drugs, because that is very unique to our population, and very soon you will see an article in Lancet. I'm one of the authors of that paper, Lancet, that Indian is a different diabetes. Our strategy should be different. And I agree with you. Can we give insulin with the sitagliptin and meat formal combination? Yes. Actually, what written very good in our ordinary textbook of diabetes, whatever oral medicine patient taking, just if you're not on target, just add basal insulin. There is nothing like that. That sulfonylurea don't combine, this don't combine, there is nothing like that. There is no trial, nothing. It is your clinical judgment. You can combine with any drug. Any other question? Can I see? One new message has come. Patient type 2 who cannot afford GLP-1, can we give insulin sitagliptin? Where is the next question actually? Organizers, can you read the question? Because one more question is pending. I'm not able to locate that question.
Sir, can we give basal insulin in above scenario?
Just a minute. Yes, basal is the best because in type 2 with oral drugs, for example, HbA1c 8 or 9, you tried your best with oral medicine, you just start with basal and you can go on increasing basal doses up to zero point 0.5 unit per kilogram body weight. So 30-35 units is not a problem. So you can push on, and sometimes it's good idea to give your sitagliptin, because sitagliptin take care. I use vildagliptin more, take care of postprandial very well. Or even sometimes people use your this medicine so-called acarbose, that we have voglibos. So it's a good idea because oral medicine with all you can combine insulin. So basal insulin is the best. Only with the best of basal with highest dose of zero point 0.5 unit per kilogram body weight. If your HbA1c more than 7, 7.5, whatever is your target. Because elderly people, your target might be 8. If you reach the target, suppose a patient is 75, 80 years old, no complication, 40 years of diabetes, no retinopathy, no nephropathy. He has some cancer. We don't want him to expect him to keep HbA1c 7. HbA1c 8 is okay for him. You start with basal, no issue. So it's more a clinical judgment, and basal is a good option. And always start with basal, because don't start with 30-70 in type 2 because there will be a lot of hypoglycemia. Basal insulin, particularly your Detimir, your because they are all available free of cost in government of Rajasthan, your Glargine or even Glargine 300. So my practice is I start with Glargine. If there is a nocturnal hypoglycemia, I use Glargine U300. Or if even then there is a nocturnal hypoglycemia, sometimes I give 30-70 only in the before breakfast. It does good job. I think there are no more questions.
No,
Can you please repeat about storage of insulin, sir, and about how many days to change needle? Yes, good question. Because most of the insulins, when they are not in use, they should be stored at 2 to 8 degrees centigrade in your lower part of refrigerator. Is clear? Once you open the vial and using it, and if you intend to use within a month time for some insulin and 6 weeks for other insulin, it depends on the manufacturer. You can keep insulin at 25 degrees centigrade. Some it depends on actually manufacturer's recommendation, but most of them recommend you can keep at temperature below 25 degrees centigrade up to 4 to 6 weeks of time. If patient is not having refrigerator, it's a good idea to have an earthen actually pot like your matki and shikora sort of thing. Keep that in a cool place, और इंसुलिन को आप प्लास्टिक की थैली में डाल के उसके अंदर डाल लीजिए, तो आप 4 वीक्स तक आराम से उसको यूज कर सकते हैं. तो इसलिए हर आदमी का फ्रिज होना जरूरी नहीं है. और कोई एग्जीक्यूटिव कोई आदमी ऐसा है हमेशा एसी में रहता है, घर में भी है और ऑफिस में भी, कार भी एसी है, वो अपने पेन को जेब में रख के और आराम से चले. वो उसको फ्रिज को सिर्फ मतलब साथ में ले आने की जरूरत नहीं है. और नीडल के बारे में देखिए, हमारे गवर्नमेंट में तो सप्लाई नीडल वो है अच्छी, मतलब आई मीन टू सिरिंज का ये है कि एक दिन के लिए एक सिरिंज मिलती है. और जो हमारे पेन की नीडल होती है वो शायद 2 या 3 दिन में रिप्लेस करनी होती है. हालांकि ऑफिशियल जो उनका जो रिकमेंडेशन होता है सिंगल यूज के लिए होती है, जो सिरिंज होती है. तो हमारे एक वायल के साथ ढेर सारी सिरिंज मिलती है हमारे गवर्नमेंट सप्लाई में. आइडियली सिंगल यूज के लिए सिरिंज होती है, बट पेशेंट 2-3 बार तो यूज करता है. इसका रूल ये है कि जब तक दर्द नहीं है उसको यूज कर सकता है. नहीं, फोर आर्म पे नहीं लगाते हैं, कि फोर आर्म की स्किन काफी थिन है और द रिस्क है उसमें इंट्रामस्कुलर लगने का एज वेल एज आपके इंट्राडर्मल लगने का. अगर आपने 90 डिग्री लगाया तो इंट्रामस्कुलर लग सकती है इंसुलिन, और आपने अगर 45 पे लगाया तो इंट्राडर्मल जा सकती है. इसलिए फोर आर्म पे नहीं लगाते हैं. आपकी जो अपर आर्म होती है डेल्टॉइड मसल के उस तरफ आप लगा सकते हैं, अराउंड द डेल्टॉइड. I hope there are no more questions. Is Puneet around or?
I think, sir, he is not.
Yeah, no problem. He busy. Can we wind up now?
Yes, sir. Yes, sir. Sure.
Okay. Thank you very much.
Thank you,
Thanks
sir.
a lot.
Thank you very much, sir. Thank you.
Thank you. Yeah.